Hi, my name is Vivek Kumbhari. I'm from Johns Hopkins Medical Institutions, and I'm excited to present our study, Initial Clinical Experience of a Steerable Access Device for EUS-guided biliary drainage. I'll present this study on behalf of Marvin Rio from Brigham and Women's Hospital, as well as on behalf of Petros Benias from the Northwell Group. Just starting with the landscape of ERCP. Really, biliary cannulation is one of the mandatory steps of ERCP. And as the ERCP is almost exclusively therapeutic now, one must be able to get into the duct of interest. However, what's the value of endoscopic ultrasound combined with ERCP? We know that EUS appears to be a cost-effective approach compared with MRCP for the diagnosis of pancreatic biliary disease. EUS allows for a single session triage to ERCP. And EUS is not necessarily now seen as an extra step for those undergoing ERCP, and I think we're now really considering these as one procedure. However, there are challenges with ERCP, and certainly achieving biliary cannulation can be one of them. It's really one of the inevitable steps for therapeutic biliary ERCP, and it can be especially challenging in patients with a periampullary diverticulum, an aberrantly placed papilla, where there's tumor infiltration around the papilla, or in cases where there's altered anatomy, such as a Biliary-2 or a Roux-en-Y gastric bypass. And failure of biliary cannulation can still occur despite the use of a double guide wire technique, the pre-cut papillotomy, and even the pancreatic septotomy. So what are some second-line initiatives for biliary cannulation? There's a pre-cut papillotomy. However, that can be technically challenging, time-consuming, can result in bleeding and or perforation, and there's an increased risk of post-ERCP pancreatitis. The double guide wire technique is being increasingly used. However, it does also increase the risk of, we know that pancreatic cannulation increases the risk of post-ERCP pancreatitis, and it can result in the need to place a pancreatic stent. And pancreatic septotomy, although it has been described, is relatively infrequently performed. So what about EUS-guided biliary drainage to help facilitate biliary cannulation? So EUS-guided biliary drainage can be performed in the same session as a failed conventional ERCP. It has superior outcomes to PTC in terms of morbidity, stent patency, resource utilization, and costs. And when you think about EUS-guided biliary drainage, there's really four categories or techniques. There's the rendezvous ERCP, the antegrade bile duct intervention, the transmural drainage techniques such as the choledochoduodenostomy or CDS, and the hepaticogastrostomy or HGS. Also, when you think about EUS-guided biliary drainage, we tend to differentiate them as whether they're a fistula forming versus a non-fistula forming EUS-guided biliary drainage technique. And I think when you're thinking about malignant disease, if someone has non-resectable disease, then any form of EUS-guided biliary drainage can be performed, although the CDS or the choledochoduodenostomy is really often preferred because it's the technically simplest and the most efficient with a low associated morbidity. However, things may get a little bit more controversial when you're looking at patients who have resectable or potentially resectable disease. And in the advent of neoadjuvant therapy, there are more and more patients who would fill this criteria. And in this case, we think that EUS-guided rendezvous or a CDS is preferred. When you think about fistula formation and benign disease, it's currently not acceptable. We don't like to form fistulas like you would with a CDS for patients who've got benign disease, as there's a risk of transient bile leak, tract dilation carries a risk of bleeding, and the tissue planes may be disturbed, making future surgery more challenging. And therefore, I think particularly in the case of benign disease, the EUS-guided rendezvous is a preferred method of approach in patients who have failed conventional ERCP. However, rendezvous is challenging. With current straight needle techniques, you've got a puncture of a bile duct and there's a risk of wire shearing. You have to manipulate the guide wire antegrade through the papilla, and then obviously you've got to switch the scope from an EUS scope to a duodenoscope. But really, I think it's the inability to manipulate the guide wire antegrade into the duodenum that's the most challenging aspect. I think this is where the Beacon EUS access system has some value. It's a novel EUS access system that allows for selective and predictable biliary access at the level of the extrahepatic ducts, and it's really engineered for rotatability or steerability and lack of wire shearing. and there's two different sizes. There's a 90 degree and a 135 degree, and this is an example of the 90 degree access system. You can see the fenestrations and the tip, which is curved, and that allows for rotation. So as mentioned, it's available in two sizes, the 135 degree and the 90 degree. And the procedure is sort of relatively known to us. We puncture, we remove the stylet, we aspirate bile, inject contrast, pass a wire. And we rotate the catheter to allow the wire to go either antegrade, or if we're unable to pass through a stricture, for example, we can go up into the liver. And in our study, in the 22 cases, there were 17 cases of malignancy and 5 cases of benign disease. And as you can see here, when we wanted to do a rendezvous for benign disease, we were successful in 100% of cases. In malignant cases, when we wanted to do a rendezvous for 14 of the cases, we were only successful in 8. However, we were very easily able to do a salvage CDS if necessary. When you think about the characteristics of the needle, the echogenicity is equivalent to current, the puncture force is equivalent, the ability to aspirate is there. What the challenges of injection are really the fenestrations. If they're even if 1 or 2 fenestrations is outside the bile duct, it can actually cause a little bit of extravasation. But the fact that you are able to anchor in a bile duct is an advantage. The rotatability is excellent, and you don't really run into wire shearing even when you use a 0.035 inch wire. So in conclusion, the access needle appears to have the following enhanced features. It allows for steerability and selective wire advancement, either antegrade into the duodenum or up into the liver. It facilitates anchoring, and there's a lack of wire shearing. Thank you.